Good afternoon, dear colleagues. First of all, let me express my thanks to organizers of Egyptian Venous Forum, especially for Professor Ayman Fakhri for invitation. I really wanted to participate in this meeting physically, but because of some geopolitical events, I had to cancel my tickets. It's my great pleasure today to share our experience on the topic, the role of MR-Phlebology in the evaluating patients with pelvic congestion syndrome. Before we begin, I would like to state that I have no conflict of interest to declare regarding to this presentation. The clinical value of advanced imaging is clear given the scale of venous-related pelvic conditions. Chronic pelvic pains affects up to half of female population, and as a vascular specialist, we must emphasize that up to 45% of these cases have a direct venous etiology. Furthermore, pelvic congestion syndrome specifically affects approximately 15% of women of reproductive age. Furthermore, from anatomical perspective, compression anomalies like May-Turner syndrome are surprisingly common, found in up to 32% of routine cadaveric dissections, with women being affected twice as often as a man. Clinically, this is of paramount importance because we see May-Turner syndrome in anywhere from 22% to 76% of patients who present with left limb DVT. This underscores the necessity of the precise diagnostic tool. Pelvic vein incompetence has two main etiologies that is dictate the surgical or endovascular treatment strategy. Primary, it is valvular defects. As it may be congenital or acquired pathology. Extrinsic, it is secondary, it is extrinsic venous compressions. Predominantly, it is nutcracker syndrome or May-Turner syndromes. Currently, our clinical decision-making pathway relies on combination of patient's symptomatology, duplex ultrasound, MR-Phlebology, ultimately catheter venography with pressure gradient measurements. Undoubtedly, transabdominal, transvaginal ultrasound remain our first-line accessible screening tools. They dictate the initial indications for further imaging. However, from surgical planning perspective, ultrasound has significant limitations. It is highly operator dependent. Gas in the bowel and the high body mass index can severely obscure view. And most importantly for us as surgeons, ultrasound lacks the accuracy required to precisely assess the degree of structure and accurately define the landing zone for stent placement and embolization. This brings us to the core of our discussion, magnetic resonance phlebography. MR-Phlebology. This modality bridges the gap between initial screening and invasive procedures. Advantages is substantial. It is completely operator dependent and highly reproducible. It often requires no contrast enhancement, which is excellent for patient safety. Moreover, it provides exceptional high-resolution visualization across axial, sagittal, and coronal planes, and allowing us to perform complete 3D reconstructions of complex pelvic venous bed. When evaluating ovarian vein incompetence, we rely on strict diagnostic criteria. We look for presence of more than 2 dilated parauterine varices. Ovarian vein diameter should be more than 6 millimeters, and specific radiological signatures such as hyperintense signal in T1 and hyperintense signal in T2. And we must also exclude obstructive pelvic masses and endometriosis. In this 3D reconstructions, we can see enlarged related parauterine veins varices, and in second picture, we can see diameter of the both ovarian veins are more than 6 millimeters. Axial view, in the axial view, the diameter of most compressed zone of left common iliac vein is more than 6 millimeters, which excludes May-Turner syndrome in our opinion. And we think it is not, it means that there are no hemodynamic significant compression. And in the second picture, we can see in axial view the enlarged ovarian veins. The literature strongly supports the diagnostic value of MR-Phlebology. Multiple studies, including works by Ahmad Asman, Surat and Menezes, demonstrate that sensitivity of assessing ovarian vein pathology ranges from 88% to impressive 100%. When we choose, let's shift our focus to May-Turner syndrome. MR-Phlebology provides crucial metric data in this pathology. Our diagnostic criteria dictates that the diameter of the most stenotic area must be less than 2 millimeters in the cross-sectional view. Furthermore, we look for actual stenotic degree exceeding, so that means more than 85%. But perhaps the most undeniable proof of hemodynamic significance is the formation of collateral veins. We look for collaterals with diameter greater than 3 millimeters and demonstrable continuity of more than 3 centimeters. In this cross-sectional view of two patients, the diameter of most compressed zone of left common leg vein is less than 2 millimeters, which matches to our criterion. In this video, we can see well-developed. Yes, here we can say well-developed collaterals from left side to right side, and full compression of left common leg vein. In this second picture, this is reconstruction of iliac veins, where we can see compressed zone and pre-stenotic enlarged zones and collateral veins. In detecting these specific parameters, MR-Phlebology is demonstrates exceptional sensitivity and specificity for May-Turner syndrome too. The diagnosis of nutcracker syndrome was confirmed by following criteria. The angle between SMA and the aorta on sagittal view should be less than 34 degrees. In normal condition, it is more than 30 degrees. The distance between aorta and the SMA in left renal vein zone should be less than 8 millimeters. In normal conditions, as you know, it is more than 10 millimeters. And the last one, it's the ratio between widest point of left renal vein and the narrowest point of left renal vein. This ratio should be more than 4 times. In this sagittal view, we can see this black line, it is angle, and the white line, it is distance between aorta and the SMA. Both of them is matched to our criteria. And this is cross-sectional way. It is widest zone of left renal vein, and this is shortest zone of left renal vein, and the ratio is more than 5 times. And in this video, we can see that another type of nutcracker syndrome, it is retroaortic. It is retroaortic left renal vein. It is another type of nutcracker syndrome. It can be diagnosed by MRI too. MR-Phlebology is also excellent for diagnosing nutcracker syndrome. It offers over 90% of sensitivity in visualizing left renal vein compression and giving us some clear morphological evidence needed before we finalize the treatment plan. In conclusion, to conclude my presentation, I want to emphasize a fundamental shift in our diagnostic approach. Magnetic resonance phlebology is no longer just an optional imaging modality. It currently serves as an essential foundational tool. It provides us with a crucial high fidelity of anatomical data that is absolutely necessary to accurately guide our clinical and surgical treatment decisions for patients with pelvic congestion syndrome. Thank you for your time and attention.